Welcome to the DaVinci Hour, a podcast series that interviews individuals across the field of medicine to help provide an inside look into their experiences and provide insight on how to navigate the journey of becoming a physician. My name is Dr. Maxwell Cooper, and I will be your host. This podcast is brought to you by DaVinci Academy, a medical education company that provides online video courses, outline format books, and clinical case videos for students studying the medical basic sciences. You can check out all that DaVinci Academy has to offer at www.dviacademy.com. All right, everybody, welcome back to the DaVinci Hour podcast. We got another great episode here for you this week. Today we're interviewing my good friend and colleague, Dr. Tai Chang. He is a anesthesiology resident here at Emory University. Just a little bit of bio on Dr. Chang. Like I said, he's in the anesthesia program here. He did his bachelor's degree at University of Michigan in Ann Arbor, Michigan, and then he did his MD at Rutgers Robert Wood Johnson Medical School in New Jersey. And we first met when we did a vascular surgery rotation together during our intern year, which Tai was forced to do, and I stupidly decided to do. All things though, it was a good rotation, and we learned a lot, and we got through it together. So, Tai, great to have you on here, man. How you doing?
Thanks for having me, Maxwell. It's weird to call you Maxwell because I always called you Cooper back from the vascular days, but I appreciate it.
Yeah, definitely. So I think we'll just dive right in. I mean, I think we were talking a little bit before we started recording, like what rotation are you on right now and how's that going?
So I'm currently a couple months into my second year of my anesthesia rotation. So I'm a PGY2, which means typically for anesthesia residents, you're starting your now clinical anesthesia year one. So if you consider July 1st as the first month of your clinical anesthesia year, I am now starting my July, August, September, October, fourth month of general anesthesia.
Oh, wow.
So I'm on my fourth month general anesthesia. I just recently switched sites. I was doing my general anesthesia rotation at Grady Memorial Hospital, which is the community hospital that's affiliated with Emory. Now I'm at home base, I guess you could call it, which is EUH.
Nice. So I guess getting in, I'm aware of anesthesia, obviously, but I feel like I just didn't get much exposure to it in med school. And I feel like it's one where students if they don't rotate on it, they maybe don't get a full exposure. I guess, what would you say your typical day is, especially when you're doing general anesthesia? What are your responsibilities? When does your day start? Take us through it.
Yeah, absolutely. So that's a great point. Admittedly, when I was in medical school as well, my exposure to anesthesia before I committed to a career in it was very limited. And then, funnily enough, as I've begun residency and actually starting my anesthesia training, I'm learning way more about the field than I did before. I'll start off by answering your question by actually debunking some of the myths. I don't have a favorite puzzle or Sudoku puzzle. I would actually love at this point in my career to actually be afforded that sort of flexibility in the OR to do it.
Yeah.
During training, unfortunately not. But my typical day on a general anesthesia rotation begins the day before. Part of the reason why, even for today's podcast recording, I had to push it back a little bit is the night before our actual day begins, our evening involves calling our attending. We use our remote EMR access. We look up our patients, what room we're in the next day, and then we kind of do a little bit more deep pre-op evaluation of the patients we'll be caring for. And that usually entails kind of going through their medical history, anything in their medical history that is more pertinent to the way that would affect our airway management, for instance, or fluid requirements or pressure management, these kind of things. And then for any case, we always are pretty concerned about cardiac history, past surgical history, anything that would affect our positioning, anything that iatrogenically that we do may worsen their already existing medical issues. And then once we've kind of gone through that medical history and figured out what kind of things we should be concerned about, then we make a plan for for the anesthesia that we run by our attendings. It's a little bit odd to do that the night before, and that was something I was not really privy to before I came into med school. But it is nice because at most you're doing about 1 to 2 to 3 at most cases that you will cover for the next day. And then the actual day of, like tomorrow, it really depends on which site you're at least for our program. But the first surgery will start at 7:30. So that means that we're usually in by around 6, by 6 a.m. Because I just recently changed sites and everything logistically has been a nightmare for me, just like relearning everything. So I give myself a little bit more of a buffer, and then I go in, set up the ORs, and then we go see our patients once they roll in the pre-op. Then we do another second check just to make sure that nothing has happened since I looked at the computer notes, such as the patient eating after midnight, which would delay the surgery. We look at morning labs for patients who are diabetics. We'll usually do like a point of care lab draw. And then the most daunting task, which is placing that first start IV, just because, IVs are no fun to start off with, but putting them in some of the patients who are very sick and don't have very good vasculatures, it makes it a little bit of a challenge. And then all the while we have to maintain our friendly, attitude while poking them and establishing very important good access for the surgery. And then once that happens, we roll back into our surgery and our day kind of goes by. And that's where, each case by case, you do your own anesthetic plan that we discuss. Sometimes, again, last minute we may call audibles, or at least are attending well, and we'll adjust our plan. But if all of that goes smooth, then our day typically ends by 3 p.m., at which point anesthetist, we could kind of maybe talk about that later, but that's another, it's on the mid-level provider that exists in our field that will come to relieve us at 3, at which point then I go back to kind of our home base and we do consent and pre-op evaluations where we write notes for patients, for a select number of patients that will be responsible for also taking to the OR the next day. And then we do that phone call again with our attendings for the specific cases that we'll be assigned to.
Interesting.
That's pretty much it.
That's pretty cool. So I didn't realize you guys do a lot of your, I guess, pre-charting, if you will, like versus like medicine or surgery, they would come in very early and do it versus you guys do it the night before, which I think probably makes like the morning a little bit less stressful, I would imagine.
We do it to make it as less stressful as possible. If we were to do it all the morning of, oh man, that would be pretty tough. Yeah. Without delaying surgeries and such. And so.
Nice. No, that's cool. And then, so I've always wondered, like, do you guys do any type of like rounding or like actually going up? Cause I feel like I've seen you guys like drop notes before where like you evaluate, like you said, like you evaluated the patient and things like that, but they're not in the pre-op, like they're inpatient or something. Is that something that you guys are responsible for doing, or do you only do that like when they finally get to pre-op area?
So I think when people think of anesthesia, they think of general anesthesia, which is what happens mostly intraoperatively, although I think the modern day anesthesiologist will actually spend time in the perioperative arena. So like kind of like the pre-op I was telling you about. And also something I didn't mention, I guess I forgot to mention in between cases, there's also post-op. The PACU is called post-anesthesia care unit. So you're in that realm, and when you're usually sticking around in that realm, you won't do what you were just mentioning, Cooper. But then as far as there are subspecialties within anesthesiology where your home base is actually not the intraoperative arena, if you will. So for instance, at Grady, when we have our general anesthesia rotation there are some days where we are assigned to be on the acute pain service. So in the field, like as a fellowship, that the way you get to that point is doing a regional fellowship or acute pain fellowship. And what these providers do is they are experts of acute pain, like post-operative, post-surgical pain.
Interesting.
And sometimes not even that, it could be post-traumatic pain. And what you do in those cases is you may actually be a consultant to a primary surgery team or a primary ICU team or a medicine team. And when multimodal, these days, most teams are very good at multimodal management, but if that fails, they may consult this team and use their expertise to seek more escalated forms of pain management in the form of sometimes epidurals, sometimes they'll do what's called Q pumps, administration of medications more invasively, that by design is to give better pain control, but all the while with the goal of weaning and properly managing pain acutely and then gradually coming off of medications with adverse side effects.
Gotcha. Now, is that the pain management service, or is that something separate from the pain management service that you're describing?
Yeah. So generally, I think it's going to vary hospital by hospital, kind of whatever system they have in place. But at least at Grady Memorial Hospital, just because I'm familiar with that, that was the pain service.
Gotcha.
The pain service that team consulted was the acute pain service.
Okay. And I think we'll get a little more into that later on, but I think that pain management is definitely a very interesting subspecialty of anesthesia as well. That I think, again, people aren't necessarily familiar with that is like a subspecialty. So cool. Okay. So you said you're on like a general anesthesia rotation. I guess what other types of like you said you were about to start doing like subspecialty rotations. So like what type of rotations like are you doing as an anesthesia resident?
Sure. So outside of general will cover a lot of cases, like a lot of surgical cases from ophthalmology, ENT surgery, trauma, acute care surgery, general surgery, ortho surgery, urology. That's mostly it, I think. That's what I can think of. And then if you do now subspecialties, it's the way they have been kind of partitioned is based on the type of anesthesia that we provide is kind of vastly different. So one of them that's coming up for me after I finish my general surgery stint is OB.
Okay.
So labor and delivery, and then acute pain and chronic pain. So there's two types of pain. And then also doing cardiac. We do ICU. The modern day ICU is very different from how it used to be several years or decades ago. So there are like closed unit ICUs, at least at our institution, where anesthesiologists are the primary providers in these ICUs, are the cardiothoracic ICUs, where you are specifically taking care of patients who are status post cardiac surgery, the different kinds, because these patients require pretty involved post-operative resuscitation, like through ECMO and then pressure requirements. Peds anesthesia is another rotation. And then we also do neuro anesthesia, which can fall under general anesthesia for some people. And I'm trying to think if there's one I'm missing. I think that's it. I think those are the main ones. Although that being said, there are more fellowships that are currently available, albeit not all ACGME accredited. For instance, there's like a transplant fellowship you can do, but the reality is there's no institution, I think. Emory is known for its liver transplants, but it's probably be difficult to do a month of just liver transplants, just because the volume is not as high as other surgeries. And also those surgeries are really tough. So just to have one person sitting through one of these, like what could be 18-hour surgery cases every day would probably be unreasonable.
Yeah. Awesome. Yeah. So it's, I guess one thing I didn't real like, I think I was relatively aware that anesthesia did ICU. I just didn't fully, especially like talking to you. And then like when we were on vascular, we were down in the vascular ICU a lot. And that would seem to be run by an anesthesia service or anesthesia attendings and residents and fellows. And I guess it's like really like critical care is like a major like subspecialty of anesthesia. I think aren't there anesthesiologists that do almost exclusively critical care as attendings? Is that right?
Correct. Especially in the private setting, from what I'm starting to learn as I'm thinking about career beyond residency, you can definitely have an exclusive critical care kind of work environment. In the academic institutions, you are given the flexibility of wearing multiple hats. You can be some days in the OR. Usually these attendings who balance between OR and the unit. Okay. They'll do like a week on, week off kind of thing. And it just keeps things so that they don't lose their intraoperative skills. And then also carries over into the ICU, some of the skills that you needed in the OR.
Oh, okay. So it's like the pulmonologist who will do like a week in the medical ICU, and then they do like a week in pulmonary consults or something. Same type of
Correct.
like schedule. Okay.
Yes, very much.
And do you guys typically tend to work more in surgical type ICUs, or is it really you guys could work in theoretically could work in any type of ICU?
As it currently stands, I believe it's mostly, if you do an anesthesia critical care fellowship, it will be in a surgical type of ICU.
Gotcha.
Although, when looking at some of these programs, they have you do months that are not in the surgical ICU, though.
Gotcha. Okay. I think you touched on some of this. I guess like it sounds like your typical hours are like 7 to 3. Obviously, if you're on call or things like, or if cases run over, that can change. Is that kind of a typical like hours for you guys per week, or does it vary? I guess maybe.
Yeah, it varies on the rotation. So that's pretty much your general anesthesia schedule, where you do work weekends and you do heat calls, and then kind of the thing that I was mentioning before, where you're doing like those pre-ops. And I think this is going to vary institutionally, but
Sure.
at Emory, we will do these pre-ops after we're done with the OR. So we're kind of relieved. We'll work on some pre-ops, and there's some educational benefit you could argue from doing some of those. So you were still working on patients and such. And that takes about anywhere, it'll vary on the caseload. In the thick of the recent Delta surge, when cases were low, the amount of pre-ops that we were required to do decreased. And then other parts of the season where caseload is very high, where there's a lot of traumas, then your caseload will go up. And so we would be out of the OR by 3, and then our days could go anywhere from 4 to 5, I would say on average.
Gotcha.
Yeah.
Okay. Speaking of call, like I guess one, like how often you guys take call? And I realize that probably varies like on the program and things like that. But I guess like when you do take call, like, is it overnight? Like, what are you responsible for? Obviously probably like emergency surgeries, but also probably maybe things like code blues or things like that. I guess maybe take us through like what like a typical call shift is like for you guys.
Sure. And it's going to completely, even within one institution, it's going to vary between which site you're at. So since I'm most familiar with the Grady calls, when we do our 24-hour calls, that means you're usually doing your normal day shift. And then at 3 p.m., when you're relieved, now you're responsible for carrying we call it the AR, the anesthesia resident, which means the first call resident phone. The calls you get from that phone are usually for any traumas that come in. So from 3 p.m. until the next morning, you are responsible for any trauma that come in. Living in Atlanta, you and I know because you're reading all these images, Cooper. So like, there's a lot of traumas that come in. And so your night can be crazy busy where you are running traumas back to back. Cool thing about running traumas back to back and what differentiates your day shift when everybody's there from the night shift is at Grady, you play like a pretending role as early as like my first month of doing general anesthesia. What that means is I get to start every case. If one compares anesthesia to kind of flying a plane, which is often used analogy, you're basically doing all the takeoffs and then you do all the landing of the planes. And then the primary where you're kind of sitting through the case once you've reached like the autopilot mode, and the anesthetist will be sitting in that case. That's like 99% of the times. On the rare occasions when we get completely inundated, like there's like a mass shooting or something, and we typically have 4 staff members on site. Sorry, 3 staff members on site. And you have 3 cases that have to go simultaneously. In those cases, then you may have to sit through the case.
Gotcha.
But that rarely ever happens. And other things that we're responsible for during the call, because I mentioned earlier that at least when you're doing general anesthesia, and most of the OR anesthesias, we are also responsible for the post-anesthesia care. It is our job for all surgeries to kind of sign out patients from the PACU, whether they're being discharged to home or they're being sent back to the floors of the unit. So we just need to, there's like a checklist and protocol that we follow, that they're obviously breathing well, they're close to their mental status baseline, their hemodynamics are stable, there's no nausea, vomiting, complications, things that we anticipate are complications of anesthesia. And once they've kind of checked all those boxes, then it is our role while we're on call to also make sure that we sign them out.
Gotcha. Okay.
Yeah. Yeah.
So sounds like call can be pretty busy.
At Grady
to say the very least.
Yeah, at Grady it's very busy, and just the types of cases you also get, especially if it's a trauma like your classic Grady trauma.
Yeah.
It's going to be very bloody. You're going to be administering a lot of blood. Your adrenaline's going to be kind of at max, regardless of what time of day it is. And you're just going to be doing procedures like very quickly. The ask is big, and the time will fly. That being said, we also you do urgent cases as well, and those are just as rewarding and important for patients. Those are very different from your traumas, but you also learn very interesting anesthetic techniques, and especially when in the wee hours of the night, when you have less support, you just end up MacGyvering a little bit more than you normally do, which is kind of one of the exciting parts about working at an institution like Grady. But then at Emory University Hospital is a bit different. They do different cases there. Your calls will be comprised of these 18-hour liver transplant cases, which is something that you won't see at most institutions, which is some people in our field will say those two are comparable, doing traumas and liver transplants, in the sense that you're going to have to administer a lot of blood products, and so you get different flavors, and it's just busy one way or another. Nice.
That's awesome, man. And I guess you had touched on it before. You've mentioned it, the nurse anesthetists. So like you said, they're sounds like they're almost the equivalent of the PA or NPs you see out on the floor, or on other services in your guys' field. I guess I feel like I maybe have a little bit of haziness on this still, is where does their role come in, and where I guess where do they come in all of this kind of workflow that you're talking about?
Yeah, that's a great question. So there's two primary mid-level roles that have found itself in modern day anesthesia, as I'm training. One is the anesthetist. They're also called AAs, anesthesia anesthetist. The degree path is slightly different from the other one. The other one's called CRNA. And starting with the anesthetist, I can't quote the years of number of training. I don't know that off the top of my head, but they are more or less the equivalent of physician assistants. It's kind of that sort of route. They will do bachelor's, and then I believe it's a 2-year, at least at Emory. Emory has an anesthetist school as well, and it's a 2-year where they focus on clinical and everything anesthesia. And this position is recognized by our national governing board, the American Society of Anesthesiologists. So they are in their namesake, it's their assistant roles, and they work in conjunction with us to essentially perform anesthesiology under the supervision of a physician, DO or MD. For the CRNAs are, by training, initially start off as nurses, and then they get additional advanced master's level training in a CRNA. I don't know the exact timeline of how much training goes into that, but in the end, they have a different governing body. There's no stipulations through our own governing body that they are supervised under anesthesiologists. And so in the news, some people who are, where anesthesiology may have piqued an interest as a field, they may have heard about that there are certain states that have now recently, such states like Michigan, that have acknowledged CRNAs to have some degree of autonomy in practicing. Although there's finely stipulated restrictions on where they can practice, but they may be able to do so. There's some political tension that exists between CRNAs and anesthesiologists, including between the national organizations. That has been ongoing for several years. There's been no drastic changes that has affected like our rules per se, but some people, rightfully so, are concerned about the future to some measure. As far as a resident working among both CRNAs and AAs, I feel very fortunate to be in an institution where my training has not suffered as a result of working alongside. There had always been rumors, even before I was even interested in anesthesiology as a career path, that there were some institutions that may, and I've never validated this, but just via rumors and word of mouth, where anesthesiology residents may not get more learning experience because learning experience cases would go to CRNAs or AAs. I've never found that to be the case at any of the sites, Emory, which has been great. But I do think that I could see how that could be an issue, though.
Sure. I guess as far as like administering anesthetics, like intubation, those types of things, is that typically falling on you guys or like the anesthesiology attending, or do the AAs and CRNAs do those types of things as well?
So AAs and anesthesiology attendings and CRNAs, we do the procedural stuff. The attendings are there to help us make the overall plan, and then also to bail us out should anything happen, like if there is a difficult airway. So in general, we do all the procedures.
Okay. And then I imagine like the pain management service, that's probably a separate thing, like because that's more, I guess, clinical, if you will, or I guess more like you're kind of like having to see patients and do clinic and things like that. Is that kind of a different type of mid-level that would be involved in that subspecialty?
Yeah. So both AAs and CRNAs have also, you will see them in the different various subspecialties as well. As far as kind of the role of the anesthesiologist, though, in those, a little bit different. And like you kind of said a couple things, but I think it's important to discern acute from chronic. So generally speaking, if you're doing acute pain, it is inpatient. Your working space will be in the hospital. You'll come in and kind of do regional blocks, administer blocks before surgeries or after surgeries or intraoperatively. And then you're doing these like post-operative pain management, whether it be through purely medical management or even procedural management. If you're doing chronic pain, that's usually more of the outpatient side. And because chronic pain as a field has evolved drastically, and there's very exciting things that's coming out of that field as far as interventions or procedures we are able to provide patients who have certain kinds of forms of chronic pain, like failed back surgery syndrome or complex regional pain syndrome. You can now offer, chronic pain specialists are now offering neuromodulation. It's a modality that has existed for a while, but is garnering a lot of interest because in the setting of an opioid crisis that is continuing relentlessly, it has been another modality of pain control that has been shown to reduce the use of narcotics. And that field is kind of exciting also because it takes your typical, this is now like if I spoke to, even some of my co-residents who are in the different fields and I asked them, like, what does a chronic pain anesthesiologist do? They probably wouldn't be able to tell me because it's so niche. And these are things I think medical students would never get on a 1 week, 2 week, or 4 week rotation. But you will spend time in the OR if you're an interventional pain specialist. And then again, doing procedures, albeit very quick. You're not doing intrathoracic surgery, but you will have a dedicated OR. You will be using sterile technique, in some cases using fluoroscopy intraoperative while doing the procedure, and kind of, being a different form of proceduralist in the OR. You won't be on one side of the drape, right, where we're used to.
Wow, that's pretty cool. Yeah, I remember at my med school there was a pain specialist that he put a lot of like pain pumps in and things like that. And it was like you said, he had his own operating room that he just ran it all day, and he would
Yeah.
do a lot of different procedures in there, which was pretty cool. Um, I guess but aside from the pain procedures, because I want to ask you about that in a little bit here, but I guess what like day to day, like what procedures like are you guys doing? Like obviously like innovations, like lines, things like that. Like what type of like what are your kind of bread and butter procedures that you guys do a lot of?
IVs you get very good at.
Mhm.
I'd say we're the expert linesmen, and women. We get it is it's already dawned upon me that even at this point in my training, the lines that the nursing staff or people can't get, they'll always ask us to kind of bail them out. And that's a part that now I didn't appreciate much, but I kind of take pride in. I think among co-residents, we kind of do that like as a joke, obviously, like who's you know proficient at putting lines, but achieving access, like when we all learned our like ABCs of traumas and such, very important. It's half, if not more than half, of how we administer inpatient medications. And so establishing access is an important thing. So we do anything from IVs to central lines to arterial lines. In the OR, I put in several arterial lines by now, a couple months into my anesthesia training, just on general. On cardiac, when you do your cardiac anesthesia months, some patients will get 2 arterial lines and, a central, your large bore IV through which you have to administer blood. And then as far as procedures, intubations come in different flavors. So we do intubations that are your standard endotracheal intubation that everyone knows from TV, like watching TV shows. You have LMA devices, which are supraglottic devices that sit above, less invasive. And then you have tons of different types of endotracheal tubes as well. You have like NIMS tube, which are tubes that are able to conduct electrical signal that's typically used in thyroid surgery, so we can stimulate muscle.
Wow.
For your VAT surgeries, video-assisted thoracoscopies, we put double lumen tubes so they could do single lung ventilation. Those are incredibly hard tubes to place based on the handful of experiences I've had. And then you also have these very small Larry tubes that for ENT and OMFS surgeries, you'll end up, because they do a lot of work in the airway, to put those. Sometimes we also do nasal airways. So we intubate their trachea by inserting a tube through their nose. Just all kinds of airways I was not familiar with before I started. And then for now pain, that kind of covers, I think, a lot of the endotracheal intubation. I guess I should talk about like spinal and epidural. These are things I've not had a lot of experience with, admittedly.
Sure.
I've done one spinal up to now, but spinal and epidural. Epidural, you're having anesthesia administered outside of the fecal space, kind of outside the dura. It takes longer to work, but a lot of LMD patients love it because it gives them good pain control during the process of parturition. And then spinals indicated for a lot of surgeries that are below the level of the umbilical, but more extensively used these days. You're going one layer deeper. That's another form of anesthesia. And all these forms of anesthesias I mentioned, you can also do in combination. It all has to do with like patient factors, the type of surgery they're getting, and we kind of optimize it. And then as far as pain type of procedures we do, a lot of regional anesthesia blocks. That basically means blocks. We get very good at using the ultrasound, and we'll do these procedures. They're very quick. Oftentimes, I would say for most orthovascular surgery procedures, I should start with vascular. This form of anesthesia will be the primary form of pain control anesthesia, because these patients will not be completely asleep during the surgery, especially if they're getting like an AV fistula graft. A lot of the patients are sound vascular, for instance.
Right.
These patients will get blocks. So they'll get some sort of upper extremity brachial plexus block, and they will be communicative with the surgeon during the surgery. And so we'll perform these pre-operatively in the pre-op holding area. And these injections it's operator dependent, but take anywhere from like 5 minutes to 10 minutes based on the anatomy of the patient. And the patients do really well. It's been quite remarkable how such a quick procedure has high yields, which is why a lot of the surgeons and the service has gotten much busier. There's more data coming out that it, again, has helped to thwart narcotic use, especially in opioid naive patients. So it's a great thing. And these regional blocks come in like a bazillion flavors. There are textbooks that have literally laid out regional techniques for every possible nerve in your body, which is kind of cool. We don't do all of them, but there's a lot of bread and butter ones we do.
That's so wild. That's awesome. I feel like when I rotated on ortho in med school, like a lot of hand surgery is done with those type of blocks you're talking about as well, right?
Yes. Yeah.
A lot of those like
a lot of plastic surgery. Yes.
Mm-hmm. Nice. Yep. Nice. I guess kind of talking about the different residency programs and paths. So you're in like a categorical program, is that right? And then there's also like the advanced, kind of like how radiology is, or like dermatology, where you do like a separate intern year, and then you proceed into your residency program. I guess, what are your like thoughts, or just kind of what you've seen from like the different options, like essentially for like doing your intern year, like whether you do it like categorical, like how you did it, or if you do a TY or prelim medicine or prelim surgery, or any other options that maybe that there are that I'm not thinking of. I guess kind of what are your thoughts on like the pros and cons of all that?
Yeah, currently there are two ways, just like you said, to approach your anesthesia residency training. Generally, you do the advanced track or you do a categorical track. Categorical, also sometimes called integrated, where you're doing all of your years under one roof, and then there's a bit more continuity between the intern year and the subsequent years. Doing that pathway, honestly, has, from what I've noticed, is kind of coming in favor. The main reason being, I think, because anesthesiology has become more specialized, like all these fellowships that are starting to get more accredited by the ACGME, has meant that like general anesthesia is also like kind of narrowing scope, and they just want more specialized advanced training, which means that they just need more months. So the benefit of doing a categorical track, which is a little bit more integrated, and the rotations you are on are more carefully selected, is all of it's kind of set up for you to kind of hit the ground running when you're in your anesthesia years, like the year I just started. Mm-hmm. So the one that I did had a good mix of surgery, and it had some months of medicine floors as well. But it wasn't like, as I just mentioned, it was deliberately planned. And so the surgery months that we did have, they wanted us to see things from the other side of the curtain or the drape, and because those would be the patients we would also manage. So I had trauma surgery, vascular surgery, which is kind of important for us because of all the access issues and such, and then kind of learning about coagulopathies and how to manage blood products and such. And then the last one was surgical oncology. I think that was our general surgery month kind of exposure, that where we got to see complex surgery. But in surgical oncology, we're quite focused on fluid management. That was something that I really got to appreciate, especially now that I do those cases. It's been a great learning experience for managing fluids intraoperatively and perioperatively. And then the medicine ones, we had like a cardiology month, and then we had neurology month, all these things that is good to learn little pieces of. And then this year we have like the foundation we picked up from intern year, but then now kind of catering more towards anesthesia. And then we had 2 months of like ICU, but we did when I had my ICU months, they were both in the cardiothoracic ICU, which was kind of a bit intimidating to start off with that as the first ICU exposure as a resident, but it got us to learn how to manage SICU patients, like surgical ICU patients, but again, specifically that niche where most anesthesiologists work. So that's one pathway. The other pathway that some of my colleagues, chose to do, and they're my co-residents now, is to do their latter 3 years at Emory, but then they did their TY year either at Emory or elsewhere. So you could do that first year come in 3 flavors. I guess technically more than that, but you could do a TY year, a prelim medicine year, or prelim surgery year, and to each their own what they want to do. But in general, when I was applying, I know that most people rank the TY year over like a prelim medicine or prelim surgery year, because the TY year affords some flexibilities. You can do rotations in surgery. It depends on the institution you do it at and what's offered, but you could kind of mix things as opposed to doing 100% one. And then the prelim surgery and prelim medicine years, as its name suggests, you're doing purely one or the other. The surgery one sounds pretty intense, but I know some people who have done that year, and I think it has benefited them immensely because they get very comfortable with different kinds of surgeries, and then also knowing how to manage post-surgical patients because they do a lot of floors work as well. And then medicine, you are just becoming kind of the all-knowing, you kind of learn how to do everything. And then the fourth one that's kind of not real is some things that we sometimes see is when people change careers paths.
Sure.
You will sometimes see somebody who did like a peds intern year and then they decide to switch over to anesthesia or something like that.
Gotcha. Yeah, I feel like from what you're telling me, probably like the year you did is maybe the most ideal because you kind of get the best of both worlds. You do some medicine and then you do some surgery. And I feel like even from my own experience, like from getting prepared for IR, obviously I didn't do as much surgery as you did, but it was nice to see like the surgical side of things, like versus just only doing medicine. And then on the flip side, like only doing surgery, it's nice, I would imagine, to see like the medicine, like get very comfortable with like heart failure and COPD and diabetes and all that kind of stuff as well. And I tell the same thing to like, medicine's interested in like IR when they're trying to figure out, I almost feel like a lot of people push the surgery year, but I feel like I tell them to also look at like doing a TY year where they can kind of mix and match and get the best of both worlds.
Yeah. I mean, it's like in the end, there's, I think, no right way to do it.
Yeah.
Kind of like there's a million ways to skin a cat kind of thing. I don't think it puts you at a disadvantage in any way if you do whatever works for you. When you start anesthesia, it's almost like restarting an intern year, as I know we kind of discussed that. You learn it's very different environment from anything else you've seen before. We have a whole different set of like diagnoses and things that we think about intraoperatively than you would think about with the same raw data that you would think about on the floors. And so everyone kind of starts from square one once you start anesthesia. So there's no advantages or disadvantages per se.
Interesting. Yeah, no, I think, for radiology, it's the same way. Like you said, there's 100 ways to do the same thing right. So yeah, it's kind of also what's, convenient for you as well. Nice. So I guess, you mentioned some, fellowships for anesthesia. Do most people, it sounds like it's leaning towards more people are doing fellowships. Do most residents who graduate now do fellowships, or is there kind of a trend towards that? Like kind of where things are with that?
I've always been told it's like, it varies. Some years there's a class that everybody wants to do fellowship, but as or everybody in medicine knows, if you do fellowship, it's another year of making kibbles and bits. Like you're not really. It's kind of hard to do at the end of training to subscribe to another year or 2 or 3 in some cases. In anesthesiology, all of the fellowships as it currently stands, they're 1 year, which is really nice. So you're not, a year goes by so fast at this, stage in our training, but it is still another year. At our institution, I would always say, I think what I've noticed is, with the exception of last year, maybe the majority of residents will choose to do a fellowship. The thing that I've always been told in general at, your major academic institutions is that that you may be pressured into. And I think people who are going to the interview cycle, soon to go through it, they'll read things on blogs saying like, you should always tell them you want to do a fellowship if you want to like be considered seriously. I don't know if that's actually true, but it does end up working out. Like, if you want to go to an academic institution where you're going to see very cool cases, advanced cases, because they have those fellowship programs and people who are highly trained. Hopefully you are considering. Otherwise, there's no reason to go through all of that and do difficult and challenging cases. And then the last thing is I've heard from some attendings who have gone through the whole job search process. Always, when you have more training under your belt, you are way more marketable than not, even having one extra month. And so that's another incentive that we've been provided to do it.
Sure. And does it matter? Because like in radiology, for example, especially now, almost everybody does a fellowship, whether they're doing private practice or academics. Is it does private practice versus academics in anesthesia seem to influence that or at all? Like, do people who are going academics seem to more so do fellowship, or does that really not come into play as much?
I think historically, if you wanted to get a good private job, I don't know exactly what that entails, but people say good private job. Maybe it has something to do with the pay or a group where the benefits are great and it's a good working environment and good location. They would not hire without a fellowship. It's just more competitive to get those jobs. So that was the case. But these days, even with academic institutions, it is hard to get, some position and be able to kind of advance your career without a fellowship.
Gotcha. Okay. I guess, are you leaning towards any type of subspecialty yet, or is you still kind of just checking everything out?
I'm still, my biggest flaw is that I'm easily enamored by all the different fields. And so I am pretty confident I will pursue a fellowship. I think it will be between chronic pain or critical care, which are vastly different things. Mm-hmm. But I could also consider, I've loved doing general anesthesia the last several months. And I could also see myself being a generalist. So I know I didn't answer your question, but I think I'm going to do fellowship. I'm not sure which one, but I could also see myself not doing fellowship.
No, that's totally fair. I mean, we both still have many years ahead of us. Yeah. For sure. I guess you mentioned critical care and interventional pain, chronic pain, excuse me. Are those two things like if you want to do those, you have to do a fellowship? Are those subspecialties where like, if that's what you want to do as an attending, you have to do a fellowship?
Correct.
Okay.
Correct.
Okay.
Yeah. These days, if you want a job to do that, yes. Okay.
And so chronic pain fellowship, you've touched on that. I imagine that's a pretty procedure heavy fellowship. And then obviously as an attending, pretty procedural heavy. I guess maybe walk us through kind of that aspect. Cause that, from what I understand is, you run a consult service, you do you guys do clinic as well. I can see like pre and post procedural evaluate. It's kind of similar to IR from what I understand. Is that true to some extent or?
Yeah, I think for chronic pain, actually, it could be these fellowships can also come in two flavors. There are actually like the fellowship programs before procedures became a big thing, like the interventional component of it became a big thing. A lot of it was actually medical management of chronic pain, which means that you're doing clinics, a lot of patients who are on multimodal pain regimen with a lot of narcotics for treating things like cancer pain and again, like chronic back pain. And then you would do medical management. And so, at the start of like the opioid crisis, when the resurgence, most recently after Jocko recognized pain as the sixth vital sign, and we had these quote unquote pill mills. These were essentially, a lot of them were like these chronic pain doctors who started prescribing, narcotics non-judiciously. Of course, with legislation and sweeping public health movements that have helped to curb a lot of the prescribing in both acute and chronic settings, we've now The pendulum is kind of swinging the other way, but in short, we've made huge strides. And so chronic pain is no longer just prescribing, although some people will still practice in that way without doing procedures. So it really depends. I've always been told, like, where you do your fellowship. Is it a fellowship where they have a lot of interventionalists who are doing that? So some people will build practices that's, very intervention heavy. Other people will do kind of a 50-50, and other people will do no interventions and kind of do a clinic like where they're doing prescription of narcotics in a safe and legal way. So that all kind of depends on your level of comfort, training, and where you are.
Gotcha. And are those the type of interventions? Are those like nerve blocks? Like what are kind of like the bread and butter interventions in chronic pain?
In chronic pain, you don't do as much nerve blocks.
Okay.
Those the nerve blocks will be regional anesthesia, like the acute pain that you do in inpatient, and that's because like the nature of those, unless you're putting in some sort of catheter that administers local for an extended period of time, it's which is usually on the order of days, nothing like well beyond that. But those, like when you're doing those, it's local anesthetics that have that like half-life of 16 hours to 24 hours. So it's great for that post-operative pain. But for chronic pain, these are people who are living with pathologies that's kind of dictating the life, and as it's not going to go away. So for these people, a huge subfield of chronic pain, interventional chronic pain, is neuromodulation. And so there are things called neurostimulators that are placed in, spinal cord stimulators that are placed in into the patient's dorsum, and then they place electrodes. You emit some sort of frequency in certain kind of pattern. It sends electrical signals that will disrupt transmission of pain signals from basically like peripherally to centrally.
Wow.
And that's like a growing field. Much better devices with more finely tuned, based on tons of research, different kind of interference like patterns that can mute, if not like mitigate, pain signals. And then there are other procedures like ablations that people do. They'll put devices like things called Vertiflex in to properly orient the spine for certain patients who have bad back pain. Those are the first things that come to mind. It's also hard to speak about that without having actually done a lot of the procedures myself. But from kind of a person of interest, like it's a very much field that's still growing, more procedures coming. And then also I know some there's a couple investigators at our own institution through the VA. She's one of our associate program directors for the fellowship program here, and she's doing for veterans. We're coming back with PTSD and having pain associated issues. She's implanting these TENS devices, which I don't even want to speak about because I don't know much about it. But basically they're devices that kind of fit just behind your ear, and she's studying kind of how she's able to mitigate headaches and PTSD for those kind of patients. So a lot of like interesting, very like above your typical like medical education stuff that's kind of happening in this field, which has been very exciting.
That's really cutting edge. That's really cool. I guess kind of winding back a little bit, when you were in medical school, it sounds like you came to the decision a little bit later. I guess what made you kind of pick anesthesia? Like, what was your process like versus picking something else?
For me, for a long time, full disclosure, I thought I was interested in surgery. And before that, I thought I was interested, before medical school, I thought I was going to do some kind of internal medicine field. So I had a tendency to I had tried out different fields. And then it wasn't until I did my surgery rotation that I was exposed to anesthesia. And kind of all the while, because I was a non-traditional student, I'd always like had extracurricular interests, particularly in the opioid crisis. So before I came to medical school, I spent 2 years in Boston. And while I was in Boston, it was kind of at the height of the modern day opioid crisis. I lived in the South End, and I saw patients overdosed on the sidewalk sometimes. And then the whole concept of naloxone, that as a rescue drug kind of came into being. And I was very, very, very interested in that. And so I pursued that work in medical school as well. And so I guess at that point, you could kind of argue was at the primary care standpoint. I was looking at the impacts of the opioid crisis. And then that evolved into, as I was developing my interests like within medicine and doing things that are procedural, I saw the intersection between kind of surgery and the perioperative environment and the opioid crisis, that patients who were receiving surgeries, were being exposed to narcotics. And then as a result, there was like prolonged use, especially in opioid naive patients. And there's anesthesiologist by the name of Chad Brumet. And then there's a couple of surgeons at the University of Michigan, my alma mater, where they were looking at this. And it was like, when I read that paper, I remember it was like sort of 10 most common surgeries that were done at their hospital. They looked at how many opioids were being prescribed and what was adequate enough, and then seeing if there was consequences of prolonged prescribing of narcotics. And that was very exciting to me because it was really iatrogenic, if you want to make it the case, meaning it's something it's preventable, number one. And if you can kind of correct that issue, it can actually solve a crisis that was prior to COVID, like the most deadly public health issue, more deadly than car accidents per year. Because I gave this like med talks during medical school about it, so I had all these like numbers memorized. But yeah, so it was a very much deadly epidemic that was going on in our country, and to be in that space where you could do something, I thought was great. So I found myself in the perioperative, thought I wanted to do general surgery, but then when I learned a little bit more about anesthesia and realized that intraoperatively it's not the surgeon who's administering any of these pain medicines, it was the folks on the other side of the drape, then I got very interested. And then I realized I didn't know anything about anesthesiology. My perception of anesthesiology was also the doctors who put everyone to sleep.
Yeah.
And right. but then I quickly realized it's way more complicated than that. And there's a lot we don't know in anesthesiology. That anesthesiology is really actually a very dangerous field if you don't do it well. And I was like very attracted to that. So I developed an attraction. And then honestly, as I've done, I guess just to answer your question, that's kind of how I fell into anesthesiology. And then when I was kind of comparing all the different fields about what I wanted, there were definitely perks of anesthesiology: the duration of training, the length of fellowships, the culture that exists within anesthesiology, and then also your kind of day-to-day. It is a field that, as we talked about already, like you're not working crazy long hours, which is great. And I think, it's hard not to think about, after going into debt as a medical student, it's hard not to also like not looking at compensation and such. And anesthesia is not in like the top 5 or anything like that, but it's in the upper half, which makes it also a practical career choice. So all these things combined, while being able to still, continue my interest in the opioid crisis, made it like a very obvious choice by the end of medical school. And then since I've begun training and like talking about all those different fellowship tracks and having done rotations as a doctor, as a training doctor, it makes me even more excited, but also more assured like I made the right choice. Because even if I wasn't so sure, like I want to do chronic pain, critical care, completely different kind of doctoring, is still an opportunity. I can still see patients. I can be a primary care patient. I can do more medical care. And if I don't want to do any of that, I can still just hide back in the OR behind the drapes, and then maybe one day play Sudoku while the surgery's going on.
No, that's really, it sounds like, you had this longstanding like interest in, the opioid crisis and how to, tackle that. And you've done a lot of research and meaningful work in that area. And then it kind of meshed with, both your personal, kind of interests and passions. And then you just found that and it sounds like you continue to find that really like it and have a passion for it, which is really cool. I had a very similar thing with radiology. Like I thought I wanted to do surgery, and then, I really liked anatomy. And then as I've gone through, same thing, I'm only a few months into radiology residency, but as I continue to go through it and do more rotations, I find more and more it was like the right fit. And definitely, and because radiology, I think, is also like kind of similar to anesthesia. You don't, like, everyone knows what a radiologist does, but like, at least superficially. But no, I think it's like anesthesia. There's much more to it than what people, just sitting in a dark room, drinking coffee and reading images all day.
We gotta keep it a secret though. We don't want to
right.
let the secret out.
Yeah. And then, as I have a strong interest in interventional as well, which is just a whole different animal as well, which again, I think a lot of med students don't fully get a understanding of what that field's all about. I guess given that, what would be your advice to like med students that maybe they're thinking about doing anesthesia, they're like in their third year, like how should they like go approach their rotations or their elective time? Like and then like even just their thought process of like kind of making that decision.
Yeah, that's a great question. I think I'm better able to answer this question because I got this question even last year and then the year before. When you're doing your anesthesia rotation, first off, I want to make a more broad statement because I think a lot of people are turned off by anesthesia because, quite frankly, as a medical student, it is such a boring rotation. And I love teaching, and I love letting medical students try a lot. That's just kind of my personal commitment to education. But as a resident, having a medical student beside you in an OR case is very hard because the thing about anesthesiology, why it looks easy from the outside, but why it's tough and exhausting actually, and why we have our field actually has the highest suicide rate, has the highest burnout rate, which is surprising. Yeah. Is because most cases can go smoothly. Some of them are stressful, but I would say on a day in and day out, if you want to do a really good job, you have to be hyper vigilant. That means it's almost comparable to taking a step 1 exam or step 2 exam, especially if you're sitting for those 7-8 hour surgeries, which is why we actually have those dedicated breaks. Because in between cases, we don't get breaks, because we're always turning over the room. We're responsible for setting up. We're responsible for catching the things that the primary team sometimes don't catch. Like they have a hemoglobin that's 8, and we should be transfusing them because we anticipate they'll have this blood loss in the surgery.
Sure.
Or a lab value, like a potassium of 7, where there's some medications we can induce with that can worsen that and put the patient in a cardiac arrest. And so we just have to be hyper vigilant when we're on. And I think by design, that's also why we only work until 3, because it's very hard to do that. Because when I do the calls, I know how exhausting it is. And so then if you add a medical student on top of that and you're trying to teach, it's like on a whole different level. And although you want to have, everyone thinks that, what's so difficult about placing a tube, what's so difficult about this? That's because 9 times out of 10, you're right, it's safe. But then that 10%, it can actually kill the patient. And that's, I fortunately, knock on wood, haven't had that happen, but not to be able to secure someone's airway, just keep jabbing and trying to put a tube in, is one of the most dangerous things. And my attendees keep telling me this too. Everybody always says, you build this confidence in anesthesia. I'm getting pretty good at my intubations. I'm getting pretty good at putting in lines. But then I'll still have that one day where there's this airway I can't get. And it will, unfortunately, the patient to have a hypoxic arrest. And I've gotten close calls where I can appreciate that. And so all of that being said, going back to the medical student, the medical student comes in, anesthesia rotation, they heard it's chill. There's the action at the start of the case. Can I try the intubation? Yeah, sure, great. But then after that, their part's kind of done, and it's it looks like a lot of charting, us kind of looking at the monitors. So I want to tell them there's still a lot going on because we're looking at things, and these are things I'm still getting better at and learning. But for the medical student who doesn't have that level of responsibility to the patient, also don't do the same level of prep for these cases. It's just like hard for them to appreciate, and they're not involved. And so that's my general statement, like disclaimer, I want to tell all medical students who do anesthesia and get turned off by that. As a resident, it's so different. As an attending, it's even more scary because you have to do this on a higher scale and run multiple rooms. So that being said, now for the people who are interested in anesthesia, what I would encourage them to do is have the experience I did as a resident. So if you have the flexibility that you do in medical school, everyone's going to say, I know I'm busy in this, but you'll never be as busy as we were as interns, like and everyone else was as interns. You have time. Seek out the non-traditional anesthesia experiences. I'm talking about the ICU. I'm talking about if your program has a chronic pain or acute pain, search those out, because there are people who finish residency who are young attendings or even, seasoned attendings that don't know what acute pain doctors do, that don't know what chronic pain doctors do. Everyone kind of has a conception, but because these fields are very niche, they just don't know. And I think being able to see those is also great. And it's something you would honestly never see unless you did that rotation. And so that's what I would also encourage medical students who are interested in anesthesia to do. Bolster your interest by seeing what's on the other side and what opportunities await.
Nice. No, I think that's great advice. Seeking out, as much exposure as possible. And I think getting exposure to not just putting people to sleep, like you said.
Yeah, exactly.
Nice. So I guess, given that, do anesthesia applicants, I realize this is different now with the whole COVID situation, but like before, like when you were applying, did people typically do away rotations? Is that something people usually did in anesthesia, or was it kind of some people did, but most people didn't? Kind of how was that played out when you were applying?
So people did. I think it was generally thought as being very favorable, but as with like all away rotations, there's like risks associated with it, especially if you don't leave a good impression. Personally, I did not do any aways, and I know that there are people that were concerned, because I've mentioned a lot of people through Twitter who were concerned during COVID that they were not able to do aways, and I reassured everybody that I did zero. Here I am, still matched. I matched at my number one program at that. So I don't think it's necessary, but it could be great if you're very serious about a specific program, which I just thought was hard to know without ever seeing it beforehand, to make that sort of commitment. But maybe you already knew of a program and you had like close friends there and you're like, I must match there. Then certainly work your hardest and leave a good impression, then that's great. But if not, it's totally fine too. Again, it's just an interesting field. Like these away rotations will serve different purposes. I think for anesthesia, a lot of it is assessing how good of a fit you are. And if you're not confident that you can, gel with most of the residents you work with and kind of display a hard work ethic, it's most likely not going to benefit you. You're certainly not going to ever impress anybody by like doing intubations. That's just not, that's not something, I mean, it's cool and you should, applaud yourself, but that's not the stuff that because I'm involved in these residency recruitment stuff too now that we talk about. It's really more like, were they a great team player? Were they, do they know when they should step in and, also kind of step out where you engage, these kind of things. So you are being observed, and it's not necessary to do so.
Gotcha. Now I realize we could probably do, kind of wrapping things up here, we could probably do a whole episode on this, but like kind of just what are your general tips you give people applying to, like they've made that commitment, they're applying to anesthesia residency, like kind of present themselves the best way possible
For interviews and stuff?
Yeah, like interviews, application, anything you can think of that are kind of like the big like hallmark tips maybe you would give somebody.
Yeah. Anesthesia, it's going to sound cliche, but communication is essential. And I think if you're able to convey that well during interview day, it's going to serve you well. And then the other thing that's essential that you get endorsement of from about this in your MISP or MISP equivalent letter from your medical school, your rotation reviews, and then the interview day as well is like your willingness or your commitment to being a good team member. Mm-hmm. It's not always the case, and leadership, all that stuff is great too. But the reality is when you're thinking about most of intra-op OR, I'm not saying that anesthesiologists aren't leaders. There are times we have to step up, but first and foremost, before being considered a leader or anyone, this goes for the surgeon as well. You have to be willing to be a good team player. You have to learn to put your ego aside and where you're there for your intraoperative team when they needed you, and then even outside of the OR among medical student colleagues or resident colleagues, we're a good team member. Those are the things that I think will serve you really well if you can have those things said about you applying to anesthesia.
Nice. All right. Well, Ty, I've certainly learned a lot about anesthesia. Certainly a lot that I didn't know before. Kind of our last.
You're going to apply to anesthesia?
No, I think I'm going to stay where I'm at, but I think people out there should definitely consider it. It's an even more interesting field than I always thought it was a very diverse and cool field, because you guys do a lot of medicine, but then you're also doing procedures and you're involved in a lot of different aspects of patients' care and things like that, which I think is really interesting. You do a lot of you have different subspecialties like critical care, pain management, or acute pain, which I didn't even know about that, the acute versus chronic pain difference, which I think is really cool. So that's awesome, man. And I guess our last question is, when you're not doing all of these things, what are your passions outside of the hospital? How do you spend your free time when you do have it?
Well, as you know, Cooper, I have a wife, and so life's not happy without a happy wife. Happy wife, happy life. And so as much of the time I try to commit to spending time with my wife. One of the best parts of Atlanta, I think, is that there's lots to do. And so particularly we're both kind of foodies, her more than me, but we love trying food. It just makes us happy. Makes me gain weight, unfortunately, but it makes us happy nonetheless. And also I love, I'm pretty extroverted. And so I do love, talking to friends and engaging with people as much as I can. I know we've always talked about golfing. It has not yet happened, but I'd love to do that at some point.
Definitely.
And then lastly, just on a day-to-day basis, this is the small pockets of time. You already know this too. I'm on Twitter a lot. I love using Med Twitter. I think it's a great tool to connect with people. I do a lot of mentoring through that. I do research through that. I've gotten a lot of research projects up to now in anesthesia through Twitter. It's just a great medium. And I've kind of helped our program do some recruitment stuff with that as well.
That's awesome. Yeah, I know I can attest that. I'm, minuscule compared to you on Twitter. I'm late to the game, but this guy's he's a giant on Twitter. And I guess, what's your handle in case people want to follow you?
Oh yeah, it's at Ty, Tye, Chang, Chang.
Okay.
Got the original.
Nice. That's awesome, man. Yeah, that's rare. You can get your actual, just your name, no numbers or anything. That's awesome. Yeah. So yeah, we'll put that in the show notes. Anything else you want us to plug for you out there, for the listeners out there?
Nothing to plug, but I mean, everyone just submitted their ERAS applications recently, so I just want to wish everybody good luck. It's stressful no matter how you do it. You'll have good days, bad days, but just know that trust the process, everything will work out. And look, the both of us, here we are. So
yeah, we made
it. We're interns at one point now, PGY too. So no, I wish everybody good luck. I want to give a shout out to my Emory anesthesia family. I am status post day call today, so I'm a little bit tired. I even noticed my eyes are getting smaller as the conversation goes on. It's approaching my bedtime, but No, it's been great year and couple months here in Atlanta. Got to meet you. Really enjoying training here, and then look forward to the upcoming years.
Awesome. Awesome. Well, Ty, it was great to have you on the show, and I really enjoyed talking with you and certainly learned a lot. Thanks again for taking time out of your schedule to come on here with us.
It was a pleasure. Thanks for having me.
Thank you for listening to this episode of the DaVinci Hour, brought to you by DaVinci Academy. More episodes are available on our website at dviacademy.com, our YouTube channel. They're also available on Spotify and Apple Podcasts. Also on our website, you can find our video courses for anatomy, biochemistry, and histology, and they're available as month-to-month packages. They're also available as a combo package where you can get all 3 courses in one. Our website also has a store where you can find our outline format textbooks for anatomy, biochemistry, and histology. All textbooks are available in paperback version and as eBooks as well. These textbooks complement our video courses and provide a nice addition to the learning experience of allowing you to focus on the learning and not having to write anything down. On our website, we also provide a free clinical cases video series called DaVinci Cases. DaVinci Cases aims to help you learn how to answer USMLE questions and apply concepts that you learn in our courses to answering those questions. Our cases cover a variety of topics and organ systems, and they're updated frequently with new cases. And then lastly, on our website, you can find our blog, which has interesting articles that cover medical history, important figures in medicine, and innovations in medicine. Again, thank you for listening to this episode of the DaVinci Hour, brought to you by DaVinci Academy. Please be sure to tune in for our next episode.